Hello, my name is Peter Suwondo, and this fall I will be a senior at Western Reserve Academy. This summer I had the opportunity to work at the Cleveland Clinic Emergency Department as part of the Science Internship Program. My research is entitled Identification and Treatment of Febrile Neutropenia in the Emergency Department, a quality improvement project. Neutropenia is a deficiency in the number of neutrophil granulocytes circulating in a patient's bloodstream. Neutrophils are the primary type of white blood cell and are responsible for the body's immune response to pathogens. A shortage in neutrophils puts a patient at increased risk of infection. Neutropenia is actually a common side effect of chemotherapy. Chemotherapeutic agents target rapidly dividing cells and so can interfere with white blood cell production in bone marrow. This immunosuppression can be very dangerous to cancer patients, and any infections can quickly become life-threatening. Neutropenic infections, in fact, account for roughly half of all solid tumor cancer patient deaths. A fever in a neutropenic cancer patient may indicate serious infection and should be treated quickly with antibiotics in order to prevent sepsis. Since cancer patients often present to the ED for off-hour evaluations, it is important that they be diagnosed and treated as rapidly as possible. This study was designed to evaluate that process and find any opportunities for improvement. Current treatment standards dictate that patients with an absolute neutrophil count, or ANC, below 500 be given antibiotics within 1 hour. Unfortunately, when patients present to an ED, their ANC is unknown, making diagnosis difficult. To assess current treatment times, we formulated several hypotheses for testing. 1. Whether or not delays in treatment were occurring, and if so, whether they were caused by 2. Delays in provider assessment, 3. Blood draws, 4. The ordering of antibiotics, or some combination of those factors. We also hypothesized 5. That patients given a higher triage acuity level or a lower number on the ESI scale receive treatment faster. Triage acuity levels are assigned to patients to prioritize the order in which they receive care. Methodology. All neutropenic encounters between January 2008 and June 2011 were considered for the study. The 110 included encounters satisfied the following criteria. The patient's ANC was below 500, and the patient either arrived with a temperature greater than 38 degrees Celsius or listed a fever in his or her chief complaint. Encounters were analyzed for time of patient arrival, room placement, licensed independent practitioner and/or staff physician assessment, initial blood draw, antibiotic treatment, and ED departure. Triage acuity level and other metrics were also reviewed. Charts containing incomplete or illegible data were excluded from the study. Here you can see a simple overview of the ED treatment process. You can see the path from triage to room placement, assessment, blood work, and treatment. One of the main focuses of the study was to determine how best to optimize this process and which, if any, of those arrows could be shortened. Data and results. Among the 110 analyzed encounters, the average time delay between arrival and antibiotic treatment was over 3.5 hours. You can see the distribution of times on the left. A significant number of patients waited 4, 5, or even more hours before being given antibiotics, even though the average waiting room time was a mere 48 minutes. 8.9% of patients did not receive antibiotics, and this may easily have been caused by a number of factors which this study was not designed to assess. In these cases, it may not in fact have been appropriate to use antibiotics. On this screen, you can see the average ED treatment timeline. The colored blocks at the top proportionally represent the median amount of time spent waiting for a particular treatment event. The two largest blocks are clearly the time spent waiting for lab results and antibiotics, as well as waiting for ED departure or hospital admission. Each of those time periods is roughly 1/3 the patient's total length of stay in the ED. Blood is not drawn until a median time of around 1.5 hours. Here you can see a plot of triage acuity level and treatment time over the sample period. Treatment time is a moving average in orange, while triage acuity is blue. A lower number on the Emergency Severity Index, or ESI scale, represents a higher triage priority, so the axes have been matched up. As you can see, there is little correlation between the two graphs. We'd expect a dip in ESI number to be accompanied by a decline in treatment time, but this is clearly not the case. This control chart illustrates average treatment times over the 3-month sample periods. Though there is some fluctuation in the treatment times, overall they hovered around 3.5 hours. The thick black line in the middle represents the grand average, while the other lines represent standard deviations away from the mean. Analysis. Treatment delays occurred and were caused by a number of factors. The longest delay occurred while waiting for blood test results. Other delays occurred because of time spent waiting for room placement, independent practitioner assessment, and initial blood draw. No significant relationship between triage acuity level and treatment time could be established. Patients also waited a significant amount of time, 1/3 the total length of stay, between antibiotic treatment and ED departure. This increased the risk of exposure to infectious diseases. Conclusions. There appear to be numerous barriers to rapid identification and treatment of febrile neutropenia in the ED. 1. There are delays in treatment, and patients wait an average of 3.5 hours for antibiotic treatment. 2 and 3. There are opportunities to both improve the time between arrival and provider assessment and to more quickly obtain blood samples. 4. Assuming that most lab tests take 1.5 hours to complete, antibiotics are administered quickly once lab results become known. There's an average delay of 16 minutes, insignificant when compared to other waiting times. Finally, there is no correlation between triage acuity level and antibiotic treatment time. Recommendations. Universal treatment time standards may in general increase the speed and efficiency of neutropenic encounters. In any case, since lab tests take approximately 90 minutes to complete, drawing and sending blood to the lab earlier in the encounter presents the single greatest opportunity to improve treatment times. This is illustrated in the following slides. In addition, the research suggests that an expedited hospital admission process may be needed to shorten neutropenic patients' time in the ED, and that some patients may be treatable with empiric antibiotics before their ANC count is known. As of July 2011, the Cleveland Clinic Emergency Department has adopted a new split-flow intake model. This slide illustrates that model, which aims to separate patients into more and less sick patients groups and optimize treatment for each. The most noticeable change is that patients will now be assessed by an independent practitioner immediately upon arrival. This lends us the opportunity to draw blood for testing just minutes after they arrive. This opportunity is best illustrated in the proposed treatment workflow you can see now. The present ED treatment timeline as determined by the study is at the top of the slide. As you can see, there's a delay of almost 2 hours between blood draw and antibiotic administration. That's the light blue bar. That's the light blue bar. Since lab testing accounts for roughly 85% of this time, the potentially most effective way to reduce treatment time is by moving that blood draw to the beginning of the encounter. This allows lab testing and other events like provider assessments to occur simultaneously, potentially reducing treatment times by over 1.5 hours. The proposed neutropenic workflow can be seen at the bottom of the screen. Other discussion. In order to see whether the split flow model actually results in lower treatment times as expected requires further study and comparison to the treatment times determined in the study. Further research is needed to determine which factors contributed to delays in the patient group receiving antibiotics over 4 hours after arrival, and to determine the reasons which some patients did not receive antibiotics at all. As other potential measures to improve treatment times, we suggest that chemo patients be further educated about the need for prompt evaluation and treatment of neutropenic fevers. And we also suggest that patients be given wallet cards or other materials identifying them as high acuity patients to ED triage nurses. References and my final acknowledgments. I'd like to thank my mentors in the Emergency Services Institute, Dr. Elaine Thaler and Ms. Pam Black, for all their support. I'd also like to thank the Office of Civic Education Initiatives, particularly Ms. Rosalind Strickland and Ms. Nedra Starling, for making this opportunity possible. Thank you.